Bismillahirrahmanirrahim. The topic I'm going to speak about today is peripheral neuropathies. This is a diagram to demonstrate a neuron. Neuron is the unit of the nervous system, whether central nervous system or peripheral nervous system. The neuron is formed of a cell body containing most of the cell organelles. It has many small cell processes called dendrites, and it also has a large central cell process called the axon. The axon is surrounded by an outer layer called the myelin sheath, and the outermost layer, which is called the Schwann cell layer. The axon and the Schwann, the axon, myelin sheath, and the myelin sheath and the Schwann cell layer are not a continuous layers. They are interrupted at what we call those nodes of Fourier. The function of the axon is the transmission of the impulse in one way from the cell body to another neuron in case of neural junction, or to the muscle in case of neuromuscular junction. Transmission of the impulse occurs through two ways. First way through the axon, which is called the axonal transmission. Second way of transmission of the impulse is through the nodes of Fourier, what we call saltatory conduction. We can notice here that the saltatory conduction is much faster compared with the axillary conduction, or with the axonal transmission. Why I'm bringing this slide? Because when there is a partial injury of the nerve, we can demonstrate, or we can differentiate between two types of pathology: demyelinating neuropathies and the axonal neuropathies. In the first, in the axonal neuropathies, a damage is mainly in the axon. This occurs in most in diabetes mellitus and in most of the cytotoxic drugs with cytotoxic neuropathy. In this case, the axonal transmission is lost, but the saltatory conduction is preserved. So the conduction velocity is little, if any, affected, which is usually normal or slightly reduced. On the other hand, we have immune-mediated disorders that target the myelin sheath, like Guillain-Barré syndrome. In this case, the axonal transmission is preserved, but the saltatory conduction, which is the faster conduction, is affected. So there is a marked reduction of the conduction velocity. By the word marked, we mean that there is reduction of conduction velocity by more than 30% below the lower limit of the normal. This is also another diagram to demonstrate how the peripheral nervous system is formed. Started by two roots, anterior spinal roots or motor roots, posterior spinal roots or sensory roots. Two roots unite together in the intervertebral foramina to form spinal roots, to form the spinal nerve. Spinal nerve then pass into plexus, which gives off the peripheral nerves. The topic of the aim of this lecture is directed towards the peripheral nerve, not to the root or to the plexus. If you are confronted with a patient with a rested dope, this is an impairment of function of individual nerve, which is the radial nerve. If you are confronted with a patient with a foot dope, this is impairment of the function of individual nerve, which is the common peroneal nerve. So this is a localized pathology, which may be entrapment, may be trauma, or localized infection. On the other hand, if you are confronted with a patient with medial nerve affection or ulnar nerve affection on the right and left side, or sometimes medial nerve on one side and ulnar nerve on the opposite side, sometimes medial nerve on the one side and then common peroneal nerve in the opposite side, which may develop at the same time or later on by 2, 3, or 4 months. This is what we call multiple mononeuropathies or mononeuritis multiplex. So it can be divided as simultaneous or sequential involvement of the individual nerves, either partially or completely, evolving over a period of days to years. So it may be at the same times bilateral ulnar nerve, or sequentially ulnar nerve on one side and later on medial nerve on the opposite side, or common peroneal nerve on the opposite side, or facial nerve. The deficit, as the disease progresses, the deficits becomes more confluent. As a whole, the pattern of involvement is asymmetrical. So even if we have a medial nerve on the right and left side, this pattern, the involvement is asymmetrical. They are not in the same severity. But as the disease progresses, for example, for patient with leprosy, or patient with diabetes, or patient with cholangenic vascular disease, the deficits becomes more confluent, and sometimes it is symmetrical bilateral, simulating peripheral neuropathies, which is the subject we are going to talk about today. Here we come to the peripheral neuropathy. Peripheral neuropathy, this is impairment of function of all peripheral nerves. simultaneously and symmetrically on both sides. So it has to be symmetrical on both sides simultaneously in the same time on both sides, with involvement of both motor and sensory fibers of the distal segment of the peripheral nerves. So the cause in this case is usually it has to be a systemic cause, like diabetes mellitus, like renal failure, like hepatic failure, like systemic inflammation, which is not localized anymore. So here we can understand one important message, that the term peripheral neuropathies is not a diagnosis, it's localization of the pathology to the distal segment of the peripheral nervous system, which has many causes. Before we proceed to the causes of peripheral neuropathies, how can we diagnose a patient or a case of peripheral neuropathy? The onset will be acute or subacute or gradual according to the etiology. If we are talking about something like Guillain-Barré syndrome, the cause will be acute or subacute. If we are talking about diabetes mellitus, in this case, the onset will be gradual and progressive. So the onset may be acute, subacute, or gradual according to the cause. This involvement of the motor of the peripheral nerve, motor and sensory nerve. For the motor, there is weakness of lower motor neuron types, which may affect the lower limb or upper limb, although the lower limb is usually early and more severely affected compared to the upper limb. Why? Because the fibers run a longer course. The weakness of lower motor neuron types, which is associated with hypotonia, associated maybe muscle atrophy, decrease in the deep tendon jacks. The weakness is symmetrical bilateral, affecting the limbs distally more than proximally. So they may be associated with S-dope, foot dope, or high steppage gait. The deep tendon reflex, as I mentioned, is lost or absence. Superficial reflexes are usually not affected. They may be absent, but if they are present, the plantar response means flexor. Sensory manifestation may be subjective or objective. Subjectively, the patient may complain of paresthesia, numbness, tingling sensation, burning sensation, pins and needle sensation, usually in hands and feet. There may be pain or sometimes muscle cramps. Objectively, there is loss of sensation in the distribution of glove stocking, so glove and stocking hypothesis. And by the word glove and stocking, we means glove and stocking literally. So it has to be symmetrical bilateral, right side exactly like left side, medial aspect exactly like lateral aspect. No one is putting on stocks on one side and leaves the other side bed, or putting using long stocks on one side and short stock on the other side. It has to be symmetrical bilateral, medial aspect like lateral aspect. So we know that peripheral neuropathy means impairment of the function of the peripheral nervous cells of the distal segment of the peripheral nerves that showed motor and sensory manifestation, distal weakness, lower motor neuron manifestation, glove and stocking hypothesis. So the second step, what is the cause of polyneuropathy? As any pathology, it could be hereditary or acquired. Hereditary causes, we have to differentiate between two types of inherited neuropathies. Neuropathies of unknown causes. This type is more important to us as neurologists because the patient will be presented just with peripheral neuropathy, no other system affection. In this example is the hereditary motor and sensory neuropathies or Charcot-Marie-Tooth. This is autosomal dominant disorder. The manifestation usually starts in the second or third decade, sometimes early, sometimes late, with gradual onset and very slowly progressive polyneuropathy. In this case, it is very symmetrical. Right side is exactly the left side, even on the electrophysiological pattern. On the other hand, we have inherited neuropathies due to specific metabolic or other defect. These types of neuropathies is maybe more interested to the internist or to the pediatrician because it affects the nervous system, the peripheral nervous system, among other systems. The best example is hereditary amyloidosis, porphyria, and disorders of the lipid metabolism. As I mentioned, polyneuropathy can be inherited or acquired. So the acquired causes is very important. Why? Because it is more common for the peripheral neuropathy. Second, because there is a treatment for them. So we have to consider the acquired polyneuropathies and have to look for the treatment. Acquired polyneuropathy may be inflammatory, and inflammatory can be categorized into two subgroups: infective, in which is the invasion of the nervus with a causative or with a microorganism. This may be a bacteria like leprosy, diphtheria, botulism, Lyme disease. It may be a virus like HIV, like infectious mononucleosis or virus hepatitis. The other بنسمع حاجة systemic infection like TB, like typhoid, schistosomiasis or malaria. On the other hand, the inflammation may be immune mediated. And the best example of this is the Guillain-Barré, acute polyneuroagiculopathy. This means that there is usually a preceding event before the onset of the virus. The preceding event is usually upper respiratory tract infection or gastroenteritis. Then the patient passes into a latent period and then it develops the paralysis. In this case, the preceding infection it triggers immune mechanism. This immune mechanism lead to formation of antibodies that co-act with the peripheral nerve myelin. Best example, as I mentioned, it's a Guillain-Barré syndrome or acute demyelinated polyneuroagiculopathy. Other causes apart from inflammation, it may be due to systemic disease. For example, paraneoplastic syndrome, connective tissue disease, sarcoidosis. It may be due to metabolic and endocrinal disease. Metabolic disease like diabetes mellitus, like renal and hepatic disorder. Endocrinal disease like hypothyroidism and acromegaly. Nutritional disorder include vitamin B deficiency, vitamin B1 deficiency, vitamin B6 deficiency, vitamin B12 deficiency. May be due drug and toxin-induced polyneuropathy. Drugs like isoniazid, like dibencylamine, like most of the cytotoxic drugs. Toxin include lead, mercury, arsenic, thallium, and we have also agricultural poisons like organophosphorus compound. Other causes include patient with chronic occlusive peripheral arterial disease, patient with chronic obstructive pulmonary disease, or patient with critical illness, critical illness disease. Critical illness, that means patient with 2 organ failure or more, patient that put on ventilator for long duration. So now we understand that we have entity called the peripheral neuropathy, which is not per se a diagnosis, it's localization of the pathology to a distal segment of the peripheral nervous system. And this بالنسبة حاجة entity has many etiologies. So for the diagnosis of peripheral neuropathy, we have to pass through 2 steps. First step is to localize the lesion to the peripheral nervous system and exclude other possibilities. Other possibilities like distal myopathies, spinal muscular atrophy, agiculopathies or plexopathies, or transverse myelitis in the shock stage. As I mentioned, weakness in the distal muscles of lower motor neuron types, glove and stroking hypothesia, aphylaxia, all of this indicates that we are dealing with a case of peripheral neuropathy. The second step, since we diagnose the patient as a case of peripheral neuropathy, is to diagnose the cause of peripheral neuropathy. Some helpful point that is the types of polyneuropathy. We don't have a pure motor polyneuropathy or pure sensory neuropathy, but we have predominantly motor polyneuropathy and the predominantly sensory polyneuropathy. Predominantly motor polyneuropathies include Guillain-Barré syndrome, acute inflammatory demyelinating polyneuroagiculopathy. We have diphtheria, we have botulism, we have Lyme disease, we have lead intoxications. Okay. For on the other hand, sensory neuropathies, we have diabetes mellitus, we have leprosy, we have alcoholic neuropathies, we have nutritional or vitamin deficiency neuropathy, amyloidosis. So, if we do a nerve conduction, now we can differentiate between demyelinating and axonal neuropathies. There is a marked delay of the conduction velocity, more than 30%. More than 30%, this means that we are dealing with demyelinating neuropathies. If the conduction velocity is normal or slightly affected, this means that we are dealing with axonal neuropathy. Demyelinating neuropathy, the only disorder I want you to remember is acute inflammatory demyelinated polyneuroagiculopathy. Axonal, most of the cases or most of the etiologies like diabetes, like renal failure, like amyloidosis, like leprosy would cause an axonal neuropathy. Other investigation, nerve conductor study, DDLMG, CSF, show a nerve biopsy rarely needs, but sometimes it is needed for patients with chronic neuropathies. ESR, CBC, C-active protein, hepatic and renal function, fasting blood sugar level and postprandial blood sugar level, vitamin B12, collagen screening, and if we are suspecting that the patient has a paraneoplastic polyneuropathy, we have to screen for the underlying tumor. Now we give an examples of some of the acquired neopsis. First example is mainly multiple neopsis or Guillain-Barré syndrome. By definition, Guillain-Barré syndrome means an acquired, immunologically mediated polyneuroagencolopsis that develop over days or weeks but no longer than 4 weeks. So it's acquired, if we go, it's an acquired immunologically mediated. That say again, it is not an infective, it is a post-infective. So there is a preceding event which occurs 1 to 4 weeks precede before the development of the paralysis. Usually the patient complains of upper respiratory tract infections or gastroenteritis, and there are certain organisms that has been linked to the development of Guillain-Barré syndrome, including Mycoplasma pneumonia and Campylobacter jejuni. So this acquired immunologically mediated polyneuroagencolopsis that developed over a period of days or weeks. This means that the disease is not localized to the peripheral nerve, but it may extend up to the roots in the next few days or weeks. So we can remove the whole sentence, polyneuroagencolopsis that developed over a period of days or weeks, and what one word is, it is ascending weakness or ascending pulse, but no longer than 4 weeks. No longer than 4 weeks, because if the propagation extends beyond 4 weeks, this means that it is no longer acute, it is the chronic form or the chronic inflammatory demyelinating polyneuropsis, which has a different lines of treatment and also a different prognosis. If we talk about etiology, pathogenesis, and pathology, that, as I said, there is a history of preceding event in 50% or up to 2/3 of the patient. The preceding viral infection or preceding bacterial infection trigger immune response that lead to formation of antibodies that cross-react with the peripheral nerve myelin. Pathologically, there is loss of myelinated fiber. Among these loss of myelinated fiber, this endoneural vascular inflammatory infiltrate. If we do a teasing of the individual nerve fiber, we can see that there is multifocal demyelinating patches affecting any segment of the peripheral nerve, starting from the anterior motor roots up to the intermuscular branch, with the main site of the lesion or the main lesion is usually is anterior ventral roots. That's why the disease is more motor than sensory. Clinically, the disease onset is usually subacute. The patient starts to complain of weakness, which may affect the 4 limbs together, or more commonly start in the lower limbs, and then in the next few days it extends to involve more proximal muscle to affect the upper limbs. The disease may affect the pelvic girdle muscles, shoulder girdle muscles, the trunk, and more seriously, it may affect the respiratory muscles, lead to respiratory insufficiency that necessitate mechanical ventilation. It may also affect the facial muscles. The weakness is floor motor neuron type. This is, let's say, it is associated with hypotonia and aphyxia. The weakness is distal and proximal. As I said, the disease starts in the distal, the peripheral nerve, and then extend proximally. So the weakness is distal and proximal, and sometimes it is as severe proximally as distally. Sensory manifestation is usually mild. As I mentioned, they may be associated cranial nerve affection. In this case, the patient may have facial nerve, which may be unilateral or bilateral. They have external ophthalmoplegia or even affection of the lower corneal nerve nuclei. On the other hand, of lower cranial nerves, the pathology may be also associated with autonomic manifestation. Investigation will depend on, first, CSF. CSF will disseminate to show protein cell dissociation. That's to say, cells are normal, but there is marked elevation of the CSF protein. It may reach 400 or 600 or even more milligram per deciliter. Nerve conduction study, as I said, this is immune-mediated demyelinated disorder, so there is a marked reduction of the conduction velocity. This a diagram to demonstrate that the weakness is distal and proximal, and lower limb and the upper limb. Some of the patient may be even paralyzed and confined to wheelchair or bedridden patient, and sometimes they may, as I said, they may affection of the respiratory muscles that necessitate mechanical ventilation. Treatment. This is an important. This is a general mention. Whenever you suspect that the patient has a Guillain-Barré syndrome, it has to be hospitalized for the whole period of expected deterioration. The whole period of expected deterioration, according to the definition, is about 4 weeks. But usually the deterioration occurs in the first 2 or 3 weeks. During this hospitalization, you should be careful monitoring of the patient regarding the respiratory function, regarding the blood pressure and the heart rate and the autonomic function, because sometimes the patient may needs emergent intervention. Some of the patient may be bedridden, and so they need the classical care for bedridden patient. That's to say, care for the eyes, care for the skin, care for the nutrition, care for the sphincters, and a prophylactic dose of heparin, that's to say heparin 5,000 units subcutaneously every 12 hours to guard against deep vein thrombosis or pulmonary embolism. The actual treatment is the removal of the antibody by plasma exchange, which is about 4 to 6 sessions, or by giving intravenous immunoglobulin in a dose of 2 grams per kilogram. Treatment of Guillain-Barré syndrome. Once we diagnose the patient as a case of Guillain-Barré syndrome, the patient has to be hospitalized for the whole period of expected deterioration. According to the definition, the deterioration may be extended up to 4 weeks. Practically, most of the patient, if they are going to deteriorate or to progress, this usually occurs in the first 2 to 3 weeks. During the period of hospitalization, careful monitoring of the respiratory function, careful monitoring of the blood pressure, careful monitoring of the heart rate and the electrolyte is required. And sometimes the patient may require admission in the ICU. On the other hand, some of the patient may be bedridden, and they need the routine care for bedridden patient. That's to say, care for the eyes and skin, care for the nutrition, for the sphincters. Some of those patients may require prophylactic dose of heparin or low unfractionated heparin, 5,000 units subcutaneous every 12 hours to guard against deep vein thrombosis or pulmonary embolism. Actual treatment is removal of the antibodies by plasma exchange or plasmapheresis. This is about 4 to 6 sessions given on alternate days therapy and should be usually started in the first 1 or 2 weeks. On the other hand, alternatively, you can use intravenous immunoglobulin if the patient cannot stand the plasma exchange or if there is a sepsis or whatever. So alternatively, you can use intravenous immunoglobulin in a dose of 2 grams per kilogram divided over 4 to 5 days. Corticosteroid has no rules. Now we give another example of peripheral neuropathy or sensory neuropathy, diabetic neuropathy. Diabetes mellitus can affect peripheral nervous system in a several ways. The most common way is distal symmetrical sensory predominant polyneuropathy. Patients with long-standing diabetes mellitus, especially if they are uncontrolled, they complain of paresthesia, numbness, burning sensation in the hands and feet, which sometimes is very painful and sometimes is disorderly to the patient. Another way that diabetes could affect the peripheral nervous system is diabetic ischemic mononeuropathy or multiple mononeuropathy. So on top of distal symmetrical sensory predominant polyneuropathy, diabetic patient may develop hand drop or wrist drop. They will develop facial nerve palsy or foot drop. So there is an ischemic motor neuropathy or ischemic mononeuropathy or multiple mononeuropathy. There are also diabetic autonomic neuropathy, and the patients complain of postural hypotension, decreased sexual potency, sphincteric disturbance, GIT troubles. Another way is the compression and entrapment syndrome. Compression and entrapment syndrome, this means there is entrapment or compression of nerve as it passes through a narrow spaces or through a tunnel. The most common is the entrapment of the median nerve as it passes underneath the transverse carpal ligament, which is called the carpal tunnel syndrome. Also, there may be entrapment of the ulnar nerve at the elbow or cubital tunnel syndrome, or entrapment of the lateral cutaneous nerve of the thigh as it passes under the lateral edge of the inguinal ligament. And lastly, we have the entrapment of the common peroneal nerve at wind around the fibular head. Entrapment may occur in any patient, but is more particularly common in diabetic patients because they usually have disturbance of the peripheral circulation, and also they have associated synovitis or tendinitis. The last way, or the last item I'm going to talk about is diabetic amyotrophy, or another diabetic radiculoplexus neuropathy. This is usually occurs in late stage or usually in uncomplicated diabetic patient or patient with severely uncontrolled diabetes. The patient will develop weakness of the anterior and the medial compartment of the thigh, which may be unilateral or bilateral. Usually, if it is bilateral, it is usually asymmetrical. And usually it involved with good control of the diabetes. Previously, This diabetic amyotrophy was considered to be some sort of diabetic mononeuritis affecting the obturator and the femoral nerve. But this has not been proved, and the pathology may be localized to the root or plexus, and once it is categorized under the name diabetic radiculoplexus neuropathy. And most common form is the lumbosacral form, but we also have cervical and thoracic form. Management of diabetic neuropathies, optimal glucose control is very important. It is effective in delaying the development of neuropathies and limiting its progression, but does not reverse it. So, the most of the cases, the treatment is symptomatic. The most common complaint of the patient is the pain, and sometimes the pain in diabetes is challenging. We can try very treatment or very drugs for the management of the diabetic pain or painful neuropathy or pain in diabetic neuropathy, starting from simple analgesic, non-steroidal anti-inflammatory drug, passing through the anti-epileptic drugs like carbamazepine, oxcarbamazepine, gabapentin, pregabalin, use of the antidepressant like tricyclic antidepressant, selective serotonin uptake inhibitors, and recently selective serotonergic, noradrenergic uptake inhibitors like duloxetine. This is the last item I'm going to speak about is the entrapment neuropathy. And the most common form of entrapment neuropathy is the carpal tunnel syndrome. As I mentioned, entrapment of neuropathy, this means entrapment of the nerve as it passes through a narrow spaces or through a tunnel formed by the bone, the joint, bone, limbs, through entrapment as the nerve passes through a tunnel formed by the bone, by the tendon or the muscle. Especially it causes close to the joint, and it is usually precipitated by pregnancy, by increase in the body weight, by common in diabetes mellitus, common in patient with rheumatoid arthritis. The best or the most common form is the carpal tunnel syndrome. Carpal tunnel syndrome, this means entrapment of the median nerve as it passes below the transverse carpal ligament. As I said, it is the most common. It affects about 1% of the population and is more frequent in female. The manifestation of carpal tunnel syndrome is usually hypoesthesia, paresthesia, or pain in the median nerve distribution in the hand. That is the lateral 3.5 fingers. Sometimes the pain may extend to the forearm, and sometimes it may extend even the whole limb, causing brachialgia. Examination in this case will demonstrate sensory loss in the median nerve territory in the hand. It may demonstrate also positive tunnel test. What is to cause tapping, that is to mean tapping of the median nerve at the wrist will elicit pain in the median nerve distribution. Another حاجة motor manifestation is usually minimal, and it is usually sometimes in neglected case found wasting in the sena group of muscle, mainly في الابductor bulges beefs. Diagnosis will depend on the nerve conduction study to demonstrate the delay in the conduction velocity in the transcarpal segment. Treatment may be conservative treatment starting from analgesic drugs, using night splint to manage or to minimize the movement of the joint. Sometimes we use a local injection with corticosteroid or even anesthetic drug, and finally we may need surgical decompression of the nerve. That's all what I want to talk about peripheral neuropathy. Thank you for your attention.